Welcome to In Circulation, the podcast where we're going to explore the future of cardiovascular care, innovative practice models, and the transformation happening in the world of cardiology. I'm your host, Kristen Richards, and I'm the Vice President of Ambulatory Care at Cardiovascular Logistics. This is our very first episode, and we're excited to kick things off by discussing an essential part of modern cardiovascular care, and that is ambulatory surgery centers and office-based labs. These innovative models are helping the practices scale. They're also helping them deliver on their mission of providing exceptional care to their patients and also helping them be successful in this ever-evolving healthcare landscape. Today, we're joined by Dr. Mubbasher Syed from First Coast Cardiovascular Institute, where he's leading efforts in integrating ASCs and OBLs into their care delivery model. Dr. Syed, thank you for being with us today. And I know we're on a new journey because you've had an existing OBL and now your ASC is soon to open. So it's exciting things happening in Jacksonville, Florida for your community at large. So thank you for being here today.
Thank you for having me, Kristen. It's honestly a pleasure. It's a very interesting topic as we were talking off camera just a few minutes ago. This is something I'm really thrilled to talk about. I feel very passionate about outpatient migration, and I really think it is a very relevant conversation in the current milieu, where we are seeing a lot of this happening across the country. Yes, as you said, we have had an office-based lab for quite some time, and now we are transitioning to an ambulatory surgical center, hopefully opening in fall this year. We are very excited for that change. We are bracing towards a clearer understanding of the key differences and similarities between these two settings. And it is a learning curve. Most of us physicians, we do not get trained in the nuances of various settings. When we are learning medicine, when we are going to training, we are mostly focused on patient-centric outcomes in the setting of their delivery, but we are not as well versed with various settings that you can deliver that care and how does it impact patient care. Um, as we start practicing, we learn how relevant that is every day. And I think this is a very important conversation to be had.
No, wonderful. And you know what? Let's start right there in just talking about office-based labs versus ambulatory surgery centers. And I want to get your thoughts on that. But let me just kind of set the foundation because office-based labs have been around really since about 2009, right? And we're starting to see this movement towards the ambulatory surgery space. And a lot of that has to do with the regulatory requirements. From an office-based lab standpoint, there are hundreds and hundreds all across the country, and they don't have the regulatory requirements to open up. And it's generally in a physician's office in one of their additional rooms. They bring in a mobile C-arm, whereas when you move towards an ambulatory surgery center, there are more regulatory requirements. You have fixed systems being brought in. The expenses are a little bit higher. But we're seeing this movement, and I think we're going to see it from CMS. They're going to push us into that movement of moving all of our ambulatory space into the surgery center environment so that they can have some more regulatory mandates really around that. So to ensure that we're delivering the highest quality care. So I don't know what your thoughts on that. How long have you had your OBL? You want to talk a little bit about that and the work that you do in your OBL?
We've had our office-based lab here in Jacksonville for nearly 10 years now, and we were one of the early adopters of that change, just in an effort to provide value-based care and to provide quicker, more patient-centered focus for our patients. But I want to jump in right there and grab the attention of any listener to the nuanced importance of regulations. In essence, when you're looking at differences and similarities in an office-based lab and ambulatory surgical center, I think the one word that is most important is regulation oversight by regulatory authorities, which means it is very relevant for clinical practices that are not regulating themselves well. So I will tell you this: in our office based lab, I'm very proud of the setting we have created. When I am in the process of looking at what will an ambulatory surgical center add to what I already have in terms of the detail and the attention to detail, and being as efficient in terms of delivery of care, as open to audit and regulation, I don't find a lot of differences down to small things and big things, like, for example, negative pressure ventilation. I have it in my office lab. The equipment I have, the kind of nursing care I have, the kind of one to one care I provide to my patients that are here. I think we are very proud about the kind of environment we have made. But yes, I will concede that not all office based labs are the same, which is why, as you said, the CMS is pushing towards more procedures to be transitioned. Even in the 2025, regulations that they released back in November last year, you would see that they're favoring surgical centers for every procedure compared to office-based labs, and that is driven by regulation. And if you want to understand the two spaces, they're both outpatient spaces. Essentially, one offers a little more oversight from regulatory authorities. So I do think it is a welcome change. I think everyone that is committed to the process, um, as in a patient-centered fashion, will welcome this change. I think it's inevitable.
I love that. And I love that you, First Coast Cardiovascular, was definitely one of the trendsetters here. You were an early adopter, as you mentioned, but can you expand a little bit more and talk about the impact how it fits in your practice, the impact it had to your patients, and then what you see as you move towards an ASC space as well?
So, truly, from a physician perspective, so if I take off the every other hat and just leave the clinician hat, the biggest advantage of having an office-based lab, which I already have, is having control of my patient's scheduling needs, my patient's same day procedures, having more control of when my patient is brought in, when the procedure is done, how the patient is treated, how the patient is discharged, how the patient is followed up. These, each of the things I said, are very crucial, are literally 90% of a patient's experience with a procedure. If you do well on all of these metrics, you have a patient that is satisfied with the care he or she is getting. And being able to deliver that in an office based setting is far more easier, conducive, facilitated, compared to in a hospital setting, for majority of procedures that are safe to conduct in an office space, must be stressed. When I talk about transitioning the same principle to an ambulatory surgical center, all I'm saying is I will be able to offer these same measures for a wider variety of procedures. I would be able to unburden my hospital schedule, um, for the hospital and for myself, to do those procedures that are low risk and can be done far more conveniently in an office space with far more control. Truly, many a times I feel like my patients are offered concierge level care when I'm doing procedures here. They feel like they have absolute control. They pick their days, they pick their slots, they pick when they want to come in and how they want to leave. Everything from down to one of the biggest aspects of office based procedural care, which I think is underemphasized, is the lack of interruption. Hospitals are amazing, but hospitals are also our our primary place for handling emergencies. How often do practitioners like me have to interrupt their procedures or cut them short because there is an emergent one waiting? That is very unlikely to happen in an office setting. And just having that uninterrupted focus and that very predictable planned day for myself and for my patients is a big peace of mind, extremely relevant to patient satisfaction and to outcomes.
I love that. And you mentioned you really focused primarily on the patients, but I'm seeing towards the end the value that it brings to you and to the practice. Can you expand a little bit more when you think about having the ability to provide this care in an outpatient setting, the value that it brings to you and all of your partners as you're delivering care in the community?
Yes, most definitely. We take pride in being trendsetters for the area, at least in Jacksonville, in trying to think out of the box and being innovators. If not innovators, at least early adopters. If we see something that is very relevant, that is making a difference, not only for the patient's health, but for their pockets, I think it is very crucial for us to be ones to jump on that train, first and foremost. And I really feel, for me and for all my partners, we feel very strongly about being the first on the value based care train. Just like we took the initiative when it was a scary space to go into office based labs, we went there, and now we are very happy that that was a good decision and people are following suit. And even CMS is paying attention and encouraging this movement of outpatient migration. Similarly, I think the next big bastion and frontier is value based care. We have a problem in the way we spend our healthcare dollars at the federal level, at the state level. There has to be some questions that have to be raised, and truly, as physicians, we have to be one of the first people to attempt and answer those questions. These questions are very simple, and they're on the wall. How in United States we are spending twice the amount of money than everybody else that is running in the first world economically developed countries, and our mortality rates, whether they are infant mortality rates or maternal mortality rates, are not in the top 10. How is it that despite spending 17% of our GDP on healthcare, our metrics are so poor? Our chronic disease burden is higher than the 10 countries that are behind us in healthcare spending. Our life expectancy for men is around 75. Other countries are averaging 80. These questions are truly to be answered in terms of accountability, and that accountability comes from finding spaces like these ones where we can deliver value based care. And people tend to focus a lot on procedures. I always like to bring more relevant examples. For example, heart failure is a big burden. From the value based care standpoint, how often does it happen? I can promise you, in almost 90% of practices in the country in the outpatient setting, when you see a patient who has acute on chronic heart failure, majority practitioners will send them to the hospital knowing that in essence, they will be receiving intravenous diuretics for 2 or 4 doses and be sent home. That will count as a hospital readmission. That is a high DRG. That is that is a burden for the economy. That is healthcare dollars being spent. Most of the time, most of my practitioners, when we see a patient that needs IV diuretics, we start those IV diuretics in the community setting, in the office setting. We give them one dose, another dose, we check their labs, we bring them back, we give them another dose. We avoid nosocomial infections. We avoid exposure to hospital, infections, hospital acquired infections. We keep them in their outpatient comfortable settings. We allow them to recover from that acute episode. We save them money. We give them a lot of convenience. And this is not a procedure, this is not a big procedure, but imagine being the patient who is receiving this care. Of course you are more satisfied, of course you are happier, and you have recovered without any avoidable major consequences of a hospital admission, and at the same time you have unburdened your hospital. So you are winning on all three fronts: on the patient front, on the hospital seeing less burden of heart failure patients, on the front of saving taxpayer dollars for healthcare to be expended in a better fashion. Why would you not jump on this train?
Great insights. I mean, just fantastic feedback on that, and so true. And it brings me to the next. And you're highlighting so much of those questions around patient experience. So in the ambulatory surgery centers, they're now required. We've been required to report on our patient experience, and you are absolutely correct. The patient experience is so incredibly high in the ambulatory surgery setting, and a lot of it is to do with so many of the things you just mentioned. Also, just thinking about lowering the cost, right? Greater access to care, easier access to care. Patients trying to navigate through a hospital, trying to park in some parking lot, and then trying to find their way to the cath lab area. They're able to drive up and park in the parking lot and walk into the ambulatory surgery center, and they're seen within minutes. It's the patient, it's very tangible to them. It brings so much value to them. I mean, you just hit on so many of those things. And our ability to provide lower cost setting environments for our patients will provide them the opportunity to get the care that they need. So thank you for that. That was just great feedback on that for sure.
So, on that point, I really want to say that we have to be very cognizant about benchmarking. It is very important for us as physicians to lead the way to prevent overutilization. If we want to have if we want to continue this movement of outpatient migration, we owe it to our patients to be very transparent and make sure that all anxiety about overutilization is put to rest. And that will only happen when we benchmark ourselves and we use third party like auditing services like Medaxium to benchmark our utilization across the spectrum. And if we see a problem, we should be the first ones to address it.
How do you think the streamlining of procedures? I'd love for you to talk a little bit more about the efficiency that you see in your OBL, and we know you're going to continue to see in the ASC, but talk to us a little bit more about the efficiency and why it's so different in the outpatient setting.
The first thing that comes to mind when you talk of efficiency is just hitting back on the point of lack of interruption. One of the things that I really feel for me when I see a complex case that requires focus, that requires lack of interruption and completely being immersed in a procedure, I think of my office space. Because in the hospital, on a day when I'm doing cases, I'm also covering the cath lab for any emergent cardiac procedures. So if there is someone having an ST elevation MI or a non ST elevation MI who's having any kind of instability, I have to keep that in mind, and that's always playing at the back of my mind. If I'm spending an extra 20 minutes ensuring that the intervention I'm doing is as perfect as I can think of it to be, if I'm doing intravascular imaging, if I'm ensuring my stents are looking good, every step that I add is a value of time, and that value of time is taking away from an emergency that is waiting. Number one, that will never happen in the outpatient space. Number two, the planning of the day is such that there is no add-ons as we have in the hospital. So you have a staff that comes in with a very clear expectation of what their day looks like, which also leads to their satisfaction. If your staff is satisfied, your patients are satisfied. They are better capable of taking care of your patients. So as you said, you have a patient who is coming in early in the morning, knows exactly what time they have to be here, park straight away, go straight, sees the doctor within minutes of arriving, sees the nurse, knows exactly the nurse that is taking care of them, and knows the communication between the nurse and the physician is not interrupted. It is such a direct mode of communication that there is very little space for miscommunication. Their procedure very often, more often than not, will happen on the time that was given to them. Their recovery time will be close to what they were told, and they will get discharged home same day in a very efficient manner. Everything about this system speaks of efficiency. And honestly, it only happens to be this efficient because it is so over specialized. Because you will see that, for example, in my office based lab, the procedure that will happen is going to be a coronary angiogram, it's going to be a peripheral angiogram, it's going to be a renal angiogram, it's going to be a peripheral intervention. Because you're only dealing with certain procedures and with certain specific physicians that are doing these procedures, and you have only a limited staff of nurses that are taking care of these patients, day to day there is so little space for variability and lability. You have so much consistency that you are able to come up with patterns that are very reproducible.
No, appreciate that. And just to take that a little step further, talk through how you decide and will continue to decide on what patients are the right fit for for the ambulatory setting.
Precisely. And this is something that I foresee will we will have more and more guidance regarding at the society level, overall, in peripheral interventions and coronary interventions, as well as in electrophysiology, because I truly believe that is the next frontier, and it is I believe we are late uh, getting on board with cardiac ablations devices, and even watchments. I believe are soon going to be done in ASCs because they are very low risk procedures. But as we add options for outpatient migration in all of these realms, be it coronary interventions, be it electrophysiological interventions, be it structural interventions or peripheral interventions, we will have to come up with more designated criterias and guidelines to guide physicians, especially the ones that are coming onto this, adopting this a little late in their career, to help guide them to pick which patients are more appropriate for the outpatient setting. These will, of course, generally speaking, be lower risk patients that are otherwise hemodynamically stable, that you feel would benefit from a more streamlined approach, that you don't need surgical backup for, which is truly a large percentage of our patients. So that is, of course, the general theme. But on a more specific side, I think there is specific guidance needed on all four fronts for physicians to be able to pick and choose more easily or in a more streamlined fashion which patients would benefit from outpatient procedures versus which ones should be considered very clearly for inpatient evaluation.
No, thank you for that. And I agree. So we have some societies input today, right, from Sky and from ACC, but they're limited. They're limited and they don't cover the whole thing. Peripherals really not in there very much. There's really nothing on the ablations because we're not there yet. We hope to see that happening in 2026, but it will require the ASCs, if the guidelines aren't there, that we're collaborating with the physicians to ensure that it's the right patient for the right procedure at the right facility, and making sure that we have all the tools that we need to provide the highest quality care and continue to live out our mission, right? Is to deliver the highest cardiovascular care available. That is our mission within CVL, and we're going to continue on that journey. So appreciate that feedback. One of the things with cardiovascular logistics is it's certainly the CVASC is a strategy, right? And it's an important strategy. And you hit on so many of the important factors on being able to provide greater access for our patients, greater patient experience, lower cost environment. And we're currently, that's a strategy we have internally, that if a group of physicians is joining the platform, if you don't have an ASC, we're going to start having a discussion around an ASC because it's so important and incredibly valuable. So thank you for all that information regarding that. You're just hitting all the main things I wanted to talk to you about on that. So let's talk a little bit about integrating into the platform, and what do you see as next steps when you think about your ASC, and then looking across the platform and all the other ASCs, what would be important and valuable to you for your ASC alongside of your other partners across the country that have ASCs in existence already?
So integration is a sweet word. It has a very positive connotation. I I love that word. It brings a lot of positive thoughts to my mind. Whenever you think about integrating systems or integrating locations, you're thinking, oh, wow, everything is going to be communicating more fluently. It's going to be all on the same page. And yes, I think one of the benefits of being in a broad platform at the cardiovascular logistics at the level like nationwide, you're bringing so many cardiologists together, all of them uh, in one way or another are like challenged by the same obstacles. So I really think we have the space to learn from each other's mistakes, from each other's challenges, and to help each other overcome them. So yes, in that sense, integration has a very positive overlook. But as truly being very honest and candid, I want to uh, I want to bring a word of advice for the platform. I, Integration is good, as Dr. Khatib often says, when it is bringing regulations and oversight. Integration should not be adding layers upon layers upon layers, because sooner than you know, you would have become difficult to navigate, as you were saying earlier. You know what I mean? So we really need to be very cognizant about every layer we are adding in the process of integration. It can be a double-edged sword too. Sometimes, for example, in our situation, you are no stranger to our situation in Jacksonville. We were lucky, we had ACA approval. We were very excited. We were ready to go live in perhaps summer or fall last year. And then when we went on the platform and the plans were overviewed by the leadership in CVL, they were like, no, we need to make some changes. And because of those changes, the advice for changes was well placed. We took that advice and it kind of postponed uh, us going live with our ASC. That has had implications. But in the future, I'm pretty sure there will be a lot of positives from that advice that came in. So it's a double-edged sword. It's a bittersweet thing. Yes, there is always at the end, there is always light at the end of the tunnel. There is more fluency in systems when integration happens, but it is a difficult process. It is a challenging process. And I really think it is very important for the leadership to be mindful that the process of integration is one of simplification, not one of adding complications and layers, because we don't want to end up in the same position where we started off.
No, and I appreciate your transparency there. And I will share this, right? The intent for the platform is that rising tides, all boats rise, right? It's how do we leverage this expertise and skill across the platform? And we have an enormous strength of wisdom among our physicians. But we also bring knowledge as well when it comes to looking at, I'll just use the example you just provided from a CV ambulatory surgery space, is that our job is to make sure that we're looking for the future, right? And that we have the growth capabilities. And the intent is really around leveraging and standardizing as appropriate. Not everything can be, right? But we certainly have a way we need to practice. We need to make sure that we are thinking years out and not just thinking about tomorrow or next year, right? We're thinking years out in our growth strategy. So great. I really appreciate your transparency around that, because we need to be clear about what are some of the challenges that we may have. I want to move on to just talking about your thoughts on the future of ASCs and OBLs. I'll give you some thoughts from my end, and then I would love to hear your perspective. We know that we're moving towards the ambulatory surgery space. There's no doubt about it. Within the next few years, the OBLs may no longer exist, right? We may need to convert or figure out what we need to do, put the infrastructure in place to convert our OBLs to the ASCs, because CMS is moving us more towards a regulated environment. I also think there's tremendous growth opportunities ahead, and you kind of hit on a couple things, but let me give you my thoughts as well, right? So the ablation component, we thought we were going to get approval from CMS to add ablations to the 2025 covered procedure list, and that didn't happen. And there's been a tremendous amount of discussion around that from major societies like HRS, ACC, around putting that proposal on for this year, and we're hoping to see again in July. We are hoping to see in July that we would see the CMS adding that to the covered procedure list, ablations. But I want to hear your thoughts on that, and then thinking through what does it look like after? You mentioned Watchmen, and I totally agree with you, but what do you think if you were just looking at ablations and then further out years, what do you think is the future for ASCs in the cardiovascular space?
It's truly a question of sustainability. I truly feel that we have to be honest about what is sustainable in terms of healthcare. Um, like if you look at the overall outlook of how the healthcare system is faring, this outpatient migration will continue to grow. There is truly no other way. Procedures that are very low risk, procedures that we are able to do in the hospital setting at the as a same day procedures for which we are discharging patients the very same day, no matter they are in the realm of electrophysiology or peripheral interventions or structural interventions or coronary interventions. Most of them will eventually, sooner rather than later, transition to an ambulatory surgical center. I do believe that the ASC space is more relevant in the future than the OBL space. It will take time to phase out the OBLs though. If I have an advice for the people that are looking at outpatient migration strategies, I think what a lot of us are talking about are hybrid models, where you have OBLs that have the capability to function as ASCs if and when that becomes the only option. Because retrofitting an OBL to become an ASC is a very expensive and difficult process in terms of regulations, in terms of how much it takes. So if you're someone who is going venturing out to get an office based lab right now, I would make sure it is capable of functioning as a hybrid model if and when it becomes relevant, because that will become relevant sooner rather than later. Forecasting what will be added to the approved procedure list is always a challenge. As you said, we were very surprised when we saw that ablations missed the train last year. Hopefully, this year we get that in. But truly, this trend is inevitable because of sustainability that is tied with it. Being able to conduct the same procedures with a half or a fraction of the cost to the patient and the payer, with safety and convenience, with higher patient satisfaction, it's a no-brainer. It's a matter of time.
Great insights, and I think great advice for those thinking about this space today. And I think it's a great thought on considering a hybrid model. I think FCCI is going to be very fortunate that they have the capabilities to convert in the future when we need to. So I think you set yourselves up pretty good. Again, thinking forward thinking leaders on the future of cardiovascular care. Any last words for the audience today when it comes to the ambulatory space? Any words of wisdom that you would like to end your discussion today?
I would just say, as I say about many things in medicine, I really think we all need to go back to studying how new trends, new innovations, how they spread across practicing communities. The same distribution of, like, innovators followed by early adopters, followed by the latecomers and the laggards. I would recommend to all my colleagues to be innovators and early adopters. I really think we owe it to our training, we owe it to our patients, we owe it to our oaths that we help the patients in means beyond controlling their blood pressure and their vascular disease. If they are paying more for the same care, if they are being inconvenienced in the hospital setting for a procedure that we can conduct much more effectively, much more efficiently in the outpatient setting, then why not consider migration? The sooner I think majority of our colleagues across the country realize that this is the right way to go, the sooner we will see uh, procedures being added to approved lists, guidelines coming from societies, more clear guidance, and more relevant regulations. Because relevant regulations are very important. That is something that will formalize the process, and adoption will lead that whole wave.
Yeah, well said. And I think over the next few years, we're also going to see some more data around this, right? There hasn't been a great deal of data, and now folks are capturing data, and we're now capturing data from a CMS requirement, from quality standpoint, from a patient experience standpoint on how well the ASCs are doing. And cardiovascular ASCs are absolutely applicable to that and have to report those metrics today. So thank you so much, Dr. Syed, for your time today.
Thank you, Chris. Thank you for having me. It was a pleasure speaking with you. And of course, your insights are far more valuable. I'm sitting in a small bubble here in Jacksonville. You're seeing the whole platform. So it was really good to talk to you. And thank you for having me.
Thank you again for all of your insights today. And thank you to everyone for tuning in to the first episode of Circulation from Cardiovascular Logistics. Please be sure to subscribe so you don't miss out on all of our future podcasts. Thank you again for your time and have a great day.